All right, gang, welcome back. We're gonna pick up where we left off, and that is with traumatic asphyxiation. And now you see on the first bullet point, it says severe crush injury. Crush injury is actually something else that can also um, happen. And basically, a crush injury is exactly what it sounds like. There is something that is crushing your patient, right? Either in part or in whole. Now, obviously, if it's, a big slab of granite, that's probably fatal. But what can happen is patients can become entrapped. They can get stuck in machinery, under machinery, right? Somebody's wrenching on their car. The jack stands fail, and now it's crushing them. Um, with crush injury, the big complication is extrication, right? They're trapped in or under this thing, and so we have to get it up and off of them or disassembled around them, right? That's more of a technical rescue, no, the fire department intervention. But what's happening to the patient's body is that section that's being crushed is not getting an oxygenated supply of blood. Right? So those tissues are getting crushed. They're not getting a fresh supply of oxygen, so they're switching over to anaerobic metabolism. They're dying, right? They're spilling their contents, so on and so forth. Lactic acid is building up. And so the tissues that are part of that crushed section are eventually dying off, and that area is becoming acidic. And so it can happen when the object that's crushing that part of the body is then released. You can now have this rush of basically toxicity that gets sent throughout your patient. Well, one of the things that we should know about the heart, right, is that it's very sensitive to pH or acidity, right? And we'll talk about acid-base balance a little bit later on. But recognize that the heart, okay, is very sensitive to electrolyte imbalances. It's very sensitive to pH, so on and so forth. And so when you have these crush injuries, you have the extrication complication, any hemorrhage associated with it, musculoskeletal injuries associated with it. Um, but as time goes on, you see these cells die, you see this buildup of lactic acid. When this crush injury is released to extricate the patient, we then have a problem, right? Now, in traumatic asphyxiation, the thing that is crushing the patient is over the chest, right? And it's causing an inability for the patient to breathe. So you're getting all of the bad stuff that we've talked about up until now. You're now also getting likely a pretty severe compromise of their ability to maintain a patent airway and their breathing. What you see here is a patient who, previously had a traumatic asphyxiation. So there's a severe crush injury causing compression of his chest, right? And so what you can see is you see a lot of bruising, right, to the chest, to the face. In some cases, you may see bulging of the eyes. We don't know if he has a tension pneumothorax. We don't know, any of these other things. Is there internal bleeding? Maybe, maybe not, right? We don't know this person's case. Um, so if you have one of these and it's not fatal, like kind of the most important thing we're trying to do is manage any hemorrhage, right? Well, then it's okay. We need to remove the object, right? And that's true of any of these crush injuries. Now, if you have someone who has been crushed for an extended period of time, we want to make sure that we do this wisely, right? And I would propose to you that you should have a paramedic there. We have some drugs that we can give that help buffer this acidity, um, but we're giving it kind of in tandem with the release of the object. We may also apply a tourniquet to an extremity if it's uh, trapped into a machine, it's actively crushed for a while, because that tourniquet would prevent any of that acidity and toxicity to get released back into the patient. But for these folks, we're supporting their ABCs, right, just as you would any patient, but recognize that there's probably going to be compromises because that's literally part of this traumatic event. Right? Managing any traumatic injuries, we're putting a priority over airway breathing, and then also for bleeding control, right? As you would any patient. For these folks who want immediate transport, again, I would suggest having paramedics available. And they can do a lot of advanced stuff with respect to airways, with respect to medication administration. So that's actually a fair bit that a paramedic could do here. You wouldn't want to delay transport, right? But if you're going to have an extended scene time, this may be a case where, okay, let's call for a helicopter, set up in the landing zone, an LZ, and get them out to the patient, because if it's going to take a while to get them cut out or extricated or whatever they're being crushed by, it may be beneficial to have that helicopter and that helicopter crew, or any paramedic really. So treat for shock, man. The nervous system has kind of two divisions. Obviously, there's a lot more to it than that, but for us, we're looking at the CNS and the PNS, so the central nervous system and the peripheral nervous system. The way I like to think about the nervous system is it's basically the computer network between the brain and the rest of the body. Right? So the brain is responsible for coordinating and organizing, right? How many body functions? A lot of them, most of them, right? And so that brain needs to be able to have a way to send signals out to the body and the body systems, and then also receive signals, right? So the output we call motor, the input we call sensory, right? So your inputs and your outputs if you're a computer. So the central nervous system is the brain and the spinal cord, right? Then from there, it branches out to be the peripheral nervous system. And that's where you're getting the sensory and motor nerves, right, as they branch out from the spinal cord. We'll see. Okay, so I'm a little ahead of myself. What we'll talk about pretty soon is going to be spinal cord injuries, traumatic brain injuries, where this anatomy comes into play a little bit more. I will call out just before we start moving on, notice the brain and the spinal cord. And so when we do spinal motion restriction, we'll talk about the vertebrae that wrap around or that protect the spinal cord, right? And you'll get to see what those look like. But that's why if there's any damage to the head, neck, or the back, we're worried about the spinal motion restriction because if one of those bony parts is fractured, if they're out of place, and they're putting pressure and they damage the spinal cord, they potentially lacerate or completely cut the spinal cord, you've now lost the ability to basically send and receive. Now, notice here you have the central nervous system, start of the brain, go down, and then this PNS, this peripheral nervous system, branches off, right? And so you see up here uh, in the cervical area, up at the top, you see a lot of it branch down, right? Send off. So there's a lot of important signals that come up here, but you also see the rest of the spinal cord. So you can think of it just like the blood vessels. Anything downstream, if cut off, won't have that communication. So that's why we're checking CSMs in all extremities, right? Because we're trying to figure out if there is damage to the nervous system, where might it be, right? Where is the signal stopping, right? And so that's why we're checking sensory and motor function. So sensory is input to the brain, motor function is output of the brain. Neck injuries, you may have penetrating wounds to the neck. So kind of a few things here. The biggest, as you see, is vascular injuries are the most common. They're also can be a bit of a complication, right? Because you can't tourniquet that. I mean, mechanically you could, but you'd be killing the patient, right? And so while we would normally use a tourniquet, we don't have that option here, right? And so, okay, well, what's our backup? All right, hemostatic agent, wound packing. Well, if I pack that, what am I compressing, right? Blood vessels, the patient's airway. Also, I have an impaled object. Well, we don't remove impaled objects, right? Also, if I'm putting direct pressure, I may now be moving that impaled object. And I can see in this case it's a knife. So as I move it, what else am I causing trauma to? What else am I damaging? So you got a pretty tricky case here, right? And so for these penetrating neck traumas, the laryngotracheal injuries where the neck's involved, you need to be careful. We need to apply, enough direct pressure to stop the bleeding. But if it's to the left and the right side of the patient, now we've basically restricted all of the blood flow. Also, I have the trachea that I need to worry about. I can't put so much pressure that I block that. And so you have this kind of tight balancing act of putting enough direct pressure to stop the bleeding, but not so much that you're cutting off the patient's ability to breathe and then also circulate blood, because you can cut off the brain, right? So for these folks, recognizing vascular injuries are the most common, but there's also some pretty important stuff back there, so we need to assess for that. So that's where you're doing your spinal motion restriction. Now you're probably not getting a stiff neck, right? You're probably not getting the normal cervical collar on this patient. So we're gonna have to go back and be creative. Okay, maybe we could use some towels or blankets. We might have to just resort to manual stabilization. You might have to use head blocks. You might have to get a little bit creative with this. The person that is stabilizing or applying direct pressure, they could likely also double as the person who's maintaining spinal motion restriction. So recognize that just because we are doing spinal motion restriction doesn't mean it has to be one of these commercial cervical collars. It could just us be holding their head. We also obviously need to make sure that we're supporting their airway, breathing, circulation. So that bleeding control is going to be doing that, managing the spinal motion restriction, and then also maybe a head tilt, chin lift, jaw thrust, whatever might be most appropriate for this patient. For this, I'd also consider a paramedic intercept. We have some more advanced abilities to manage a patient's airway, as well. Rapid transport, and again, to a trauma center. So even if the trauma center is an extra 20 minutes further, well, if you bring them to the small hospital that can't handle this, really what you're doing is just wasting time, right? Because you're going to get them to the smaller hospital. They're going to maybe do some stabilizing care while they set up a transport and bring the patient to that trauma hospital anyways, right? And so you're better off just bringing them to the hospital that they need to go to, where they are going to get that definitive care, right? Because that's ultimately what we're trying to do, is we want to get the patient to definitive care. Definitive care is the place where they're going to definitively or finally care for it, right? And then treat for shock in these patients, as we've talked about. SBS AHT, so SBS is shaken baby syndrome. That's also called abusive head trauma. Right? And you can see the graphic here, right? For whatever reason, a person finds themselves in a position where they have shaken a small child, right? And so if you think about the head and the brain, right? So the brain coordinates all of these functions. It's fairly important, right? And so it rests in this bath of CFS, cerebrospinal fluid, um, kind of floats in there. And so if you rattle their head, what you're doing is you hyperextend and flex the neck. You're potentially causing trauma to the neck, especially as it's underdeveloped in these small kids. But you're also causing a brain injury, right? So each direction, that brain's going to keep going and it's going to smash up against the skull. It's going to get damaged, right? And then you move in the other direction, the other side, right? And so you can also see that in motor vehicle collisions, right? So if you have someone who's in a car and that car gets into an accident, their head slides forward and then potentially back afterwards. Well, the head moves, the brain goes with it. The head stops, the brain keeps going, and it hits, right? And so you're going to get damage there. So this violent shaking of these kids can cause bleeding, bruising, swelling, and brain damage. And so one of the things that can happen is you have damage in the brain and it swells, you get an increase in ICP, intracranial pressure. So that increase in intracranial pressure can cause the brain not to function as well. It can cause abnormal breathing. It can cause altered mental status. Um, if that ICP becomes severe, what can happen is the brain can get pushed out through the small opening in the base of the skull, right? Because that's the only way in and out is that hole that the spinal cord goes through. So if that pressure increases, the brain's literally getting pushed through this small hole, and if untreated, is fatal. You see about 12 to 1400 children are injured or killed annually by this, which is pretty significant. And so, if you ever get a call for a pediatric patient, something seems off. Maybe they're lethargic, they're altered, they have bleeding, bruising, swelling. Maybe there's a story that doesn't quite make sense. The caretaker, parent, or whoever's there isn't quite acting right. What you need to potentially worry about is a case of this, right? So it can be an injury, it can be fatal. So another thing, right? We talked about head, neck, or back injury. We need to make sure that we're doing spinal motion restriction of this, right? So the patient likely can't adequately participate, right? Because they can't tell us if there's numbness, tingling, right? So since they can't participate, we're going to have to assume that we need to do the spinal motion restriction. Well, how do you do that, right? Our collars aren't really set up for infants, so you're going to have to either do it manually or a soft collar or come up with another solution on it yourself. For these folks, you're basically just treating the signs and symptoms, right? So you're doing a full assessment. Chances are you're not dispatched for shaken baby syndrome. Chances are you're either dispatched for trauma, or if they're trying to hide it, like lethargy or altered mental status, right? So this is probably a thing you're going to be suspicious of, and then you pick up on as you assess and you treat your patient. So in this case, recognize that we need to do spinal motion restriction. Might be a little complicated based on their size and availability of the commercial cervical collars. Any altered mental status, make sure we're checking the blood sugar. Even in our trauma patients, any altered mental status, we're checking blood sugar, right? You're obviously treating the you know, bleeding first and the immediate life threats. Um, but it is important to make sure we're getting sugars on anyone who's altered. Right? Another thing to consider is what is my scene safety like, right? If they call for lethargy, I get there, it's a little suspect, I'm asking some questions, and they might start to get agitated, they might start to get nervous, anxious, and start exhibiting behaviors that we're not totally comfortable with. So the moment you realize it might be this, certainly consider law enforcement. And then typically what I would do is um, kind of play along, get them to the hospital. There's strength in numbers. Once you're at the hospital, you can pull the nurse aside. Then you can, tell them what you're thinking, tell them what you saw. They have security and law enforcement. So, if you're ever in a case where you think it might be a little suspect and the family's getting a little squirrely, I personally play along, get to the hospital, and then kind of suss it out from there. Also recognize that you are mandated reporters, so you would have to file a report with the DCYF. Right? Skull and facial fractures. So we talked a lot about musculoskeletal injuries. We splint them, right? We immobilize the joint that we immobilize the injury, the distal joint, the proximal joint. And when it comes to the skull and facial fractures, it complicates quite a bit, right? So one of the first things is just where it is in the body, right? And what's under there, the brain, right? Pretty important. That organ dies, that organ gets damaged, we're going to have a real problem for the patient. And so if there's enough force to fracture the skull or face, okay, well, what other damage, right? Could we have concussion or contusion of the brain? Might we have brain injuries, spinal cord injuries, right? We probably need to do spinal motion restriction, right? Just because of the sensitive area and the mechanism of injury involved. Also, how do you immobilize it, right? How do you splint it? And the answer is like, good luck. It's pretty complicated, right? Um, and then even kind of more importantly, airway, right? And so is the airway pain? Did they lose teeth? Did they damage their hard palate, right? Is there maxillofacial bleeding, right? We're now worried about all of these different things, whereas had they just broken their arm, right, we're not as worried, right? You break your arm on a tree, that's one thing. You break your face on a tree, it adds all sorts of levels of complication. So we need to make sure that we're managing the ABCs, that the airway remains patent, that they're breathing adequately, we're managing circulation. Now, if you have bleeding from the face or you have bleeding into the airway, you know, we're going to be suctioning it, trying to manage it as best we can, direct pressure if it's out to the face, like we talked about. But it can be really pretty tricky. Um, you see on the right here the types of Lefort fractures. So this is just a way of kind of categorizing different facial fractures. Out in the field, you don't have X-ray vision, right? So we're not going to be diagnosing it. But if you ever hear the term like Lefort 1, 2, or 3, it just gives you an idea as to where and how in the face that it's fractured, right? Another thing, skull fractures, one of the things you want to assess for is if you can see brain matter. So anytime there is kind of a significant head injury, one of the things we're assessing for when we check the head is there exposed brain matter? Complicates a lot of things if they're even viable, right? If you're trying to manage one of these, I would suggest dry sterile dressings. You would never want to push, poke, or prod any brain matter if you find it. So you'd want to leave that basically well alone. Um, if you do see bleeding, you can try to do some direct pressure, but chances are the bleeding's coming from within the skull. So the direct pressure might actually cause more complication if the skull itself is fractured. If the bleeding's to the airway, you're going to have to suction it as best you can. In a case of this, I would certainly consider a paramedic. We have a few more interventions we could do, and also just kind of more experience with our trauma patients. Globe ruptures, so these are vision threatening events. Um, you may lose the eye. If it's isolated to the eye, probably not a immediate life threat, but it is life altering, right? This can be from a number of cases. This is a good call out for the reason you should always wear eye protection, right? Whenever you're doing construction or carpentry or laboring, right? Wearing eye protection. Um, Folks like this, make sure we're doing a full, thorough assessment, right? What other injuries may be there? Are there debris in the eyes, impaled object in the eyes, right? So on and so forth. If you have something this severe, we're probably not doing too much to manipulate the eye. I'd probably, cover over the known good eye, support their ABCs, so protect both eyes, like we talked about. Pain management can help manage the stress and help reduce intraocular pressure. Um, Something to consider, considering ALS for this as well. If it's just kind of that isolated globe rupture like we're seeing here, you need to manage the ABCs, protect the eyes, cover them up, try to manage pain as best you can, and then transport to an appropriate facility. I'd go to a trauma center for this. If there's other stuff involved, let's say it was part of a motor vehicle collision or a fall or something to that effect, right? What other injuries are there, right? So we know that they took at least some sort of a hit to the head. If this is, say, a multi-system trauma, um, so okay, spinal motion restriction, is there any other bleeding anywhere? Right, going through and making sure that we're hitting all of our wickets for the patient management in this case. Dental trauma. So, kind of a few things to consider with the dental trauma. One of the first and most obvious is airway, right? So, if there are broken teeth or teeth fragments down the airway, I need to suction those out. Well, the suction works great if it's liquid. Vomit gums up the suction, and also teeth and bone are going to gum up the suction. And so, um, what you can try to do with the suction is like get the object, pull it up, pull the object out, go back in, suction some more. Um, it's typically not advisable to ever put your fingers into the patient's mouth, but if you have to, you can see it, you can kind of pull it out. Uh, Paramedics have They're called like gill forceps. So we actually have kind of forceps that we can go into the mouth and pull things out uh, if need be. If you're really hard up, you could always roll the patient left or right lateral. So you could roll them onto their side to help kind of clear their airway, obviously being worried about spinal motion restriction. So with our dental trauma, kind of our first concern is the airway, also what bleeding is associated with this. So we want to support the airway, support the breathing, manage any bleeding that's there. Pain management, this is likely to be painful. The EMT scope, we have ibuprofen and Tylenol. You move up, advanced EMTs have laughing gas, and they have IV Tylenol. And then up at the paramedic level, we have, all of that, and then also narcotics. So just kind of gauging how much pain they're in. Also be suspicious. Could there be, right? Could there be maxilla damage? Could their jaw be damaged? What else might be injured, right? What caused this? Was it a skateboard to the face? Was it a face to the side of a wall? Was it a person who was struck by a car? Right. So now you're also starting to worry about any of this multi-system trauma as well. If you have an avulsed tooth, so like just the tooth came out, typically what you're going to do is you want to put it in a isotonic solution. So you want to put it into a solution where the salinity level is matched with the human body, so it doesn't. The tooth could be reimplantable. So you could put it in milk, you could put it in saline, you could put it in saliva. All of those have basically electrolytes that match the level of the body, and those could kind of continue to be maintained. They do make commercial. They're like small little tins, basically. Um, and you can basically put the tooth in it, and it has this compound in it that kind of is that isotonic solution. Good rule of thumb, we want to transport all of the patient with us to the hospital. All right, so if they lost a hand or lost a finger or lost a tooth or lost part of their body, good rule of thumb is we want to bring that with them to the hospital, right? And so teeth are the same way, extremities are the same way. So the dental trauma, we're managing the airway, we're managing their breathing, any bleeding control. Try to manage the pain if you're able. And then if there is a vol's tooth, storing it in an isotonic solution, right? Same thing with amputations, with digits. We don't want to just put them in ice or put them in ice water, right? That would ruin that part of the body and it could not be reimplanted. So when you do bring stuff with you to the hospital, you want to bring it in such a way where it could be reattached, reinstalled, whatever they're going to do, right? TBI, traumatic brain injury. We actually touched on this a little with the shaken baby syndrome. Right. And so you have the brain that's floating inside of the skull, it's floating in the cerebral spinal fluid, right? And it's basically cushioned, right? And so as we move throughout the world, the brain's floating in this fluid and it's protected. Well, what can happen from blast injuries, from being in a car and the car being decelerated or direct impact to the head, right? Any kind of percussive whack to the head can now cause the brain to come in contact with the skull. Um, and that contact causes damage, right? So you may have heard of the term concussion. So concussion is a traumatic brain injury, but it's without gross structural damage. So basically the difference is in a traumatic brain injury, there's structural damage to the brain, whereas in concussion, it still had an impact, it still had an injury, but it didn't structurally damage the brain tissue itself. In all of these cases, we're managing the immediate life threats, so your airway, your breathing, your circulation. You're treating your signs and your symptoms. So if there's altered mental status, you're checking the sugar. Um, for these folks, you may need to treat for shock. We want to recognize that intracranial pressure is a thing. If it increases, it can cause complications. We talked about further structural damage to the brain. Also, that brain can start to be pushed out through that hole in the base of the skull. And so what we do not want is too high of an increase in that intracranial pressure. Couple definition terms. So contusion is just a bruising of the brain. So you hear contusions a lot, you hear bruising a lot. Um, Two kind of more specific terms just to this are coup and contre-coup. So coup is a concussion at the site of impact. So let's say you get hit in the head with a baseball bat, right? Um, Basically, that's the site of the impact. And when the brain hits that part of the skull, that's coup. But then what can happen is the brain can slide in the skull and it can actually hit on the other side. So if you look at this middle one here, this acceleration deceleration injury. So you're trucking along in your car, you're in a car wreck, you have a massive deceleration, that brain's going to keep going, right? So it's going to have a site of impact. So that's your coup. But then what can happen is the brain hits and it slides back to the other side of the skull, hits over there, that's contre-coup, slides forward, and can potentially hit again. Honestly, as you're not putting this in your report, it's more interesting information to have and know. But just recognize what types of injuries can lead to either a concussion or traumatic brain injury. Recognize the difference between the two, and it's whether there's gross structural damage. Your mechanism of injury, right, should lead you to the fact that there may be a concussion, there may be a TBI. If you have a patient who hits their head and now they have nausea, they're dizzy, they have a headache, they have weakness, they're having visual deficits, right? They can't read. Chances are they have either a TBI or a concussion, right? For these folks, don't forget your spinal motion restriction. Go through the full assessment, any altered mental status. You're checking a sugar. Um, and then be on the lookout for check the pupils as well. Um, do all of your CSMs and all of your extremities. But be on the lookout for any other injuries as well. Like what led up to this. The other thing is if you have a patient and they're on blood thinners and there's any injury to the head, you really want to encourage them to go to the hospital. If you have a patient who's on blood thinners and even a small fell out of bed and bumped their head, right? You may have no visual damage or injury to the outside of the head, but if they're on blood thinners, that actually could have caused a bleed that becomes fatal, right? So that brain bleed bleeds and bleeds and bleeds and bleeds, increases the intracranial pressure, puts more pressure on the brain tissue, causing injury, and can be fatal. So if you ever have anyone who is on a blood thinner, warfarin, Coumadin, Eliquis, right? uh, Even a light tap to the head, you would want to encourage them to go to the hospital and be seen. They'd want to get a scan of the head to make sure there's no bleed. Spinal cord, spinal column. So we already saw with the central nervous system that part of that's the spinal cord, right? So it's a long, thin tubular structure made up of nervous tissue that extends from the medulla oblongata and the brainstem down to the lumbar region of the spinal column, right? So that's your CNS, your central nervous system, brain, spinal cord. Then from there, it branches off to the peripheral nervous system. Now, the spinal cord is what has the bones, the muscles, tendons, the other tissues, reaches from the base of the skull down to the tailbone. So this is what encloses the spinal cord, keeps the fluid surrounding it, keeps it protected, much like the brain, right? So it's wrapped in that, it's protected. You also have the vertebra. We should have a picture over here. Right? So you have the vertebra, and as you can see, right, it's this kind of a regular bone-shaped structure. So you have kind of the central part, you have the disc, it branches off, and so the spinal cord runs through this, and then you have the discs between, and it's floating in that CSF. And so if you have a patient who suffers head, neck, or back injury, well, what can happen is one of these can fracture, they can shift. These ends can be sharp. So this sharpness can cause trauma to the spinal cord. Um, and as as you can see here, we kind of section it off, right? So you have the cervical spine, thorax, you have the lumbar, right? And then you have your S's down here. And so one of the things that we assess for is as we're doing our spinal motion restriction, we're actually palpating each one of these, right? We're feeling for DCAP, BTLS, right? Are any of these crunchy? Are any of them fractured? Are they shifted left or right or forward or back out of place? And you can have any type of injury. You could have like a hairline, or you can have a complete fracture. You can have kind of a complete laceration through and through. And so as we go through and we assess our CSMs and assess our patient, okay, what is downstream of this part of the spinal cord potentially where's the injury, right? Now for us, we're really mostly just protecting the cervical spine, right? So our C1 through 8, and that's what our C collar is doing, right? And as you can see, we're preventing that movement of the head, neck, or the back. Because if you do have an injury here, if you have a fracture, partial hole, whatever it may be, if that's allowed to move, well, what's that bone almost directly up against? The spinal cord. And so the spinal cord is that's your input and your output for the brain, right? So that basically is your demarcation line between the central nervous system and the peripheral. And so if we have an injury here, and it's say impinging on or lacerating or causing further trauma, we now may have permanent deficits. But also, where is it and what does it control, right? So if you're kind of higher up and you sever basically the link between the central nervous system and the lungs, now the lungs aren't getting a signal to breathe, right? And so that's why we're worried. Now, you know that we protect the cervical spine. Obviously, the rest of it has, important functions and connections. But kind of the area of the cervical spine is where we're seeing like the kind of difference between life or death, right? If there's damage or trauma. One of the indications when you assess your patient that you have kind of a penetration of the system is if you see cerebrospinal fluid. So as you're assessing the patient, if you see this kind of clear yellowish fluid coming from um, the eyes, the ears, the nose, the mouth, or a penetrating wound, that would tell you that, okay, I have a penetration somewhere into the system, whether it's up at the head, coming from the skull, coming from, the spinal column. That's just going to depend where on the patient you see it. But if you're seeing this kind of clear yellowy fluid, that's telling you, okay, there's a leak in the system. That's cerebrospinal fluid, right? And so that can clue you into the severity of the damage, right? Spinal cord injuries are damage to the bundle of nerves and the nerve fibers that send and receive signals to and from the brain, right? So these spinal cord injuries, as you see, can be complete or incomplete. So incomplete injury means the spinal cord is still able to send some messages to or from the brain. People with incomplete injuries still have some feeling, function, muscle control below the site of the injury. Whereas a complete injury means that there's no nerve communication between the injury site, wherever that is, right? So they've basically lost all muscle control, feeling, function below the injury site. Now, when we're assessing the patient, we're going to have a rough idea right through our assessment, but we don't have the medical imaging. We're not going to be able to go through kind of the same full process that the hospital does, but all of this clues us into severity. So, what are some signs and symptoms of an SCI or spinal cord injury? Numbness, tingling, right? So, if they feel tingling in extremity, numbness, that's actually one of the checks that you do as part of your spinal clearance, right? Paralysis, if they just cannot move one of their arms or legs or part of it or their toes, right? Paralysis can happen from this. Weakness, if one side or both sides, they just don't have the same strength that they would otherwise, that could be an indication to us that we have, a spinal cord injury here. loss of bladder and bowel control, right? So if they're no longer continent of urine or bowel, that could be an indication that we have that. Male patients, you may also have what's called priapism, and so that's an erection caused by the spinal cord injury. So as you're doing your um, trauma assessment, if you have a male patient and they have an erection, that could clue you in that okay, we might have a spinal cord injury here, right? Because they've lost control of that function. Also, difficulty breathing, especially if it's higher up, right? If there's damage to the spinal cord between the area where the brain's telling, your diaphragm that it needs to contract every so often. That's a clue in there, right? And so, spinal cord injuries, we're looking for a mechanism of injury, right? So, some sort of traumatic event as we're doing our spinal motion clearance, as we're assessing the patient, right? We're checking our CSMs. Do I have a pulse? Do I have circulatory, right? And one of the things you may actually see neurogenic shock. So if you have somebody who, let's say, they fall, right, and they suffer severe traumatic injury, well, our body can control the size of our blood vessels, right? And our body can make the blood vessels larger and it can make them smaller, right? Well, there might be a type of traumatic injury where you lose control of that, right? So your nervous system now may no longer be able to control that. And so you may have patients who have an extremely low blood pressure. Maybe the heart rate can't keep up because there's either a pretty severe incomplete or a complete spinal cord injury, and now the brain actually can't control this part of the system. So with these spinal cord injuries, you can see all sorts of weird stuff, right? Because the brain controls, right? But now it doesn't have that ability to communicate. And so you sussing out the spinal cord injury and the trauma, a lot of it is recognizing or establishing there was a mechanism of injury, what body systems are no longer working. Well, where's the injury in the body? Okay, well, that's probably where there's either an incomplete or a complete spinal cord injury. So, as far as treating these patients, your trauma assessment script is going to lead you down the path that you need, right? It's going to tell you what to do, how to do it, when to do it. So, as long as you're following um, your your trauma assessment script, you're going to have the answers that you need. Now, I said we were going to talk about acid-base balance. I've got a few videos for you because it is, I think, fairly interesting, but it's also fairly well involved, right? And so this acid-base balance is important for you as EMTs because we talked about basically the trauma triad. We talked about the clotting cascade. What happens as the person becomes acidotic? What happens with crest injury and these sorts of things? So let's take a little peek-see here.
The body's blood pH is strictly regulated within a narrow range between 7.35 and 7.45. This is because even a minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is, an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism therefore constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms. Elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to the blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because, unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles.
Hi everyone, a lot of health students have issues with looking at acidosis or alkalosis. This is determining whether the blood is acidic or basic compared to its normal blood pH. Now, there's different types of acidosis and alkalosis. You can have respiratory or you can have metabolic. Now, what I want to talk to you about today is what makes one respiratory-based acidosis alkalosis or metabolic-based acidosis alkalosis. So like I said before, your blood pH needs to sit between the range of 7.35 and 7.45. That's the range that it needs to sit within. If it goes below this particular range, acidosis. If it goes above this particular range, alkalosis. That's the first point. Next point is when we measure pH, the H simply stands for hydrogen ions. That's all we are measuring in this case. But when we do bloods to have a look, when you get medical professionals taking bloods to have a look at whether somebody has acidosis or alkalosis, they don't just look for the pH, they also look for some other factors to tell it whether it's respiratory or metabolic. Let's take a look. All right, first thing is you must know this equation. The equation is that when you breathe, you produce carbon dioxide. This carbon dioxide will inevitably get into your blood, and blood is filled with water. So when carbon dioxide mixes with water, it produces something. The thing it produces is called carbonic acid, which is H2, there's the H2, C from there, O3, because there's 2 there and 1 there. Now, carbonic acid hates itself and splits itself apart, and it produces these two things. It produces a bicarbonate ion, and it produces hydrogen ions. Again, when we measure pH, we're just measuring this. So if somebody has acidosis, it means that the quantity or concentration of this is going up, right? If they got alkalosis, the concentration of this is going down. Now, think of this on a seesaw. If you increase carbon dioxide, this goes up and everything falls in this direction, producing more acid. So the more carbon dioxide, the more acidic. The more acidic, it means it's going down in this direction and the person has acidosis. Usually the body's very good at compensating and it will bind with that and roll back down in this direction and you'll breathe that carbon dioxide out. All right, let's talk about acidosis, alkalosis, different types. When we look at respiratory-based acidosis, alkalosis, it's looking at this end of the equation. When we look at metabolic, it's looking at this end of the equation. Now, when somebody has respiratory acidosis, what happens is it's respiratory based, something to do with breathing. Carbon dioxide is the only thing here that we truly breathe. We do breathe out a little bit of water, but mainly carbon dioxide, right? So if somebody has respiratory acidosis, the carbon dioxide levels must be increasing. Respiratory acidosis, increased carbon dioxide, because this means it binds with the water, produces carbonic acid, splits apart and produces hydrogen ions. This is acidic. That's respiratory acidosis. So what happens with the pH? It goes down, dropping down in this direction. All right, that's respiratory acidosis. What about respiratory alkalosis? Well, it's going in the opposite direction. So in respiratory alkalosis, we're not producing enough CO2. So it's not binding with water, it's not creating carbonic acid, and we're not producing enough hydrogen ions, which means we've just got an overabundance of bicarbonate, comparatively, and it becomes more acidotic. So it's a drop in CO2, which results in an increase in the pH. This is respiratory acidosis, respiratory alkalosis. What about metabolic? Metabolic acidosis. Metabolic acidosis is referring to what's happening here. Now think about it. Metabolic acidosis can happen either if you increase the amount of hydrogen ions or if you decrease the amount of bicarbonate, because bicarbonate binds the hydrogen to mop it up and get rid of it. So if that's gone, you're just left with a whole bunch of free hydrogen ions. So when you do the bloods to check for this, in metabolic acidosis, what you'll find is a drop in bicarbonate. This again is if it's uncompensated, and an increase and a drop, in the pH because it's acidosis, so it's going down. In metabolic alkalosis, what's happening is it's producing too many bicarbonate ions, or again, it could be the fact there's not enough hydrogen ions. Maybe one or the other. But what we do know is that in alkalosis, there's more bicarbonate ions if it's uncompensated. And what happens is the pH goes up as well. So this is just a very quick run through of what happens in respiratory-based acidosis alkalosis and metabolic-based acidosis alkalosis.
All right, I got one more to show you. And the whole point of multiple videos is the more you hear it by a couple different people, hopefully it'll make a little bit more sense. The one saving grace is, at the EMT level, you're not super responsible for knowing it, but I would say it's important to have an understanding as to the physiology that is actually happening under the hood, if you will.
When using the ABL blood gas analyzer, you receive a patient report which reveals the acidity, the level of oxygen, and carbon dioxide in the arterial blood. The report also contains a calculation of the level of bicarbonate. It's important to maintain a normal pH level in the blood. Therefore, the body constantly makes adjustments to keep a strict pH level, a process known as homeostasis. The pH level can be affected by, for instance, metabolic or respiratory disturbances. The body tries to maintain balance with body buffers, among others, and keep a certain bicarbonate PCO2 ratio with compensatory respiratory or renal responses. The respiratory response is quick, as the lungs increase or decrease the ventilation of carbon dioxide, which begins within minutes to hours of an acute acid-base disturbance. The renal response is slower, as the kidneys alter excretion of acid or alkaline within hours to days after an acute acid-base disturbance. When the body is maintaining a proper acid-base balance, it looks like this. But diseases, intoxication, injuries, and other disorders can threaten this balance. A simplified categorization of acid-base disturbance is respiratory alkalosis, respiratory acidosis, metabolic alkalosis, or metabolic acidosis. Respiratory alkalosis is a condition that may occur due to alveolar hyperventilation. This leads to a decrease of PCO2 in the blood, making the blood more alkalotic, and consequently the pH level is increased. If the respiratory alkalosis persists for a longer period of time, the renal system will start the process of compensation by retaining acids and increasing the excretion of buffers, mainly bicarbonate. Respiratory acidosis is a condition whereby prolonged decreased alveolar ventilation leads to carbon dioxide accumulating in the blood, which makes the blood more acidic and causes the blood's pH level to fall. In this case, the kidneys compensate by excreting acids, mainly hydrogen ions, and retaining several buffers, including bicarbonate, in order to counterbalance the low pH. Metabolic alkalosis is a condition where there is a decrease of hydrogen ion concentration, accompanied by an increase of bicarbonate concentrations in the body. This will be reflected by an increase in the pH level. A typical respiratory response is hypoventilation, which will cause the carbon dioxide level in the blood to rise, a compensatory mechanism, which may or may not be complete, but will make the blood more acidic. A renal compensation might follow in the form of retaining acids and increasing the excretion of buffers, mainly bicarbonate. Metabolic acidosis is a condition with a low pH due to accumulation of acids or decreased metabolic buffers. In the blood gas analysis, this condition shows as a decrease in bicarbonate. People who suffer from metabolic acidosis may start to hyperventilate in order to decrease the concentration of carbon dioxide in the blood. And after some time, the kidneys will compensate by retaining buffers of mainly bicarbonate and by increasing the excretion of acids. Determination of the anion gap is an important step in the diagnosis of metabolic acidosis. The anion gap is calculated from the formula, which represents the difference between the primary cations presented by sodium and the primary measured anions presented by chloride and bicarbonate. When we talk about metabolic acidosis, a normal anion gap acidosis is characterized by a lowered bicarbonate concentration, which is counterbalanced by an equivalent increase in chloride concentration, and thereby a normal cation-anion difference is maintained. For this reason, it is also known as a hyperchloremic metabolic acidosis. Normal anion gap hyperchloremic metabolic acidosis usually derives from loss of bicarbonate or diminished renal discharge of acids. It could also be due to large supplements of IV solutions containing chloride. An elevated anion gap indicates that there is a loss of bicarbonate without a concurrent increase in chloride. This can be caused by an accumulation of acids, for instance lactic acid, or toxins acting as acids. The ABL blood gas analyzer measures and calculates the respiratory and metabolic status of the patient, including anion gap, which will aid your diagnostic decisions. Watch the other videos to learn.
All right. Obviously, there's, a little bit more in there when we talk about, acid-base balance than necessarily we're going to use at our level. But again, I want to tie it together for our need, right? So it's important to recognize that there is kind of this balancing act going on inside of the patient, right? Whether they're too acidic or otherwise, right? And so, if I pump you full of saline, right, that's going to cool you down, it can lead you to be, a little more acidic. And really for us at the MT level, what we're worried about is that clotting cascade, right? So this acidity damages the clotting cascade. Also, if I'm cooling you down, that damages the clotting cascade. But also in the long term, right, you need to be within that 7.35, right, of pH balance, right? And so if you fall out of that, we have a real problem. Further, the heart rate is sensitive to the pH balance and also the electrolytes. And so it's just kind of important to recognize that there actually is a much larger balancing act going on, right? And so like all of the things that we do typically serve multiple purposes, right? So I just want to take a quick peruse. I want to look at a couple of our trauma protocols. So one of the first, we'll refresh off the acid-base balances. Let's take a look at shock, but the traumatic shock. Right, so 4.6 is traumatic shock. It's for our adult and pediatric patients. You're going to see the term here compensated, right? It's been a few weeks since we've talked about that. So compensated shock, uncompensated shock. Compensated shock is where there is shock, there is hypoperfusion. However, the body's compensatory mechanisms have kicked on and they're making up for that difference, right? And so if I, through a traumatic event, am not able to get enough oxygenated blood to the cells, but they need more oxygenated blood, well, what can I do? Well, I can breathe more times a minute. I can have my heart rate go faster. And what that can do is more quickly cycle through, put oxygen on the blood, get out, put more oxygen on, oh, great, you're back, right? And so that's why you see tachycardia and tachypnea. So heart rate up, respiratory rate up, because the body has bumped those two systems up and it's trying to compensate, right? Anxiety can make sense. You're anxious as your body knows that something bad is going on, right? And the diaphoresis, sweatiness. So you can see that, a lot in shock, but also other skin signs you can see. They may be pale, right? Ashen. It depends. So that's compensated shock, right? And so even right here, it tells you shock's inadequate tissue perfusion that impairs cellular metabolism, right? Now over here, you see for our pediatric patients, an interesting thing about pediatric patients in shock is they can compensate. Let me rephrase this. When pediatric patients compensate, it's not as obvious, right? And it's not the same as an adult. So you may actually think a pediatric patient is doing just fine, but in fact, their compensatory mechanism's going bonkers, but it can't hold on forever. So our pediatric patients, when they're in shock, they might not look as bad as their adult counterpart, but in fact, they are in compensated shock. And if we don't fix it, they will decompensate, which means their compensatory mechanisms are no longer enough. So our pediatric patients, delayed cap refill, weakening pulses, cooler extremities, altered mental status. You might see an increase in respiratory rate. And honestly, if you see any of these in adults as well, those are signs that you're in compensated shock. So you have an adult, they've suffered a traumatic event, the heart rate's up, blood pressure's up, there's altered mental status, pulses are weakening, delayed cap refill, treat them as shock. You see here hemorrhagic shock and neurogenic shock. We actually touched on that neurogenic shock earlier, but let's go through both. So you see under hemorrhagic shock, locations of blood loss include chest, abdomen, pelvis, multiple long bones. Signs of this hemorrhagic shock, meaning they're bleeding out, which causes the hypoperfusion. Pale, cool, clammy skin, tachycardia, hypotension, right? That they're losing blood. Also looking for visible signs of blood, but recognize hemorrhagic shock can be internal, right? So you can internally bleed. Neurogenic shock may occur after an injury to the spinal cord disrupts sympathetic outflow resulting in unopposed vagal tone, right? So what you saw was you have the patient, their blood pressure drops, but their heart rate doesn't go up, right? And so in neurogenic shock, the skin's warm and dry, they're hypotensive, but the heart rate hasn't increased. That's because this spinal cord injury has caused vasodilation, which drops the blood pressure, right? And that's because they have a spinal cord injury. So for these patients, we do our routine patient care. We follow the appropriate trauma protocols. We keep the patient supine, right? So on their back, controlling the active bleeding using direct pressure, pressure bandage, tourniquets, and you see the hemostatic protocol over there. Keep them warm, prevent heat loss. Right? We talked about the trauma triad, and so controlling the active bleeding, keeping them warm, right? Because we don't want them to become hypothermic. That damages the clotting or negatively impacts clotting cascade. So too does becoming too acidotic, but it's a negative feedback loop. Right, as the cells don't perfuse, you get a buildup of lactic acid. that makes you more acidic. That damages the clotting cascade, so you bleed more. If I'm pumping IV fluids that aren't heated into you, or if I'm not actively keeping you warm, I cool you down. Same thing. We lose blood, more acidosis, right? And then eventually you go into that cardiac arrest. Don't delay transport, right? And then consider hospital destination per the trauma triage and transport decision. We'll take a look at it, but you're going to see, hey, we might actually have to go the distance here for our trauma patient. And really, the only thing that EMTs will do that EMRs don't is assess blood sugar, right? Especially if there's any altered mental status. Let's actually take a look at our trauma. Where am I? Here we are. So we haven't really talked about SCI or like triage a whole lot, but basically triage, fancy term to sort, right? And basically it's how do we most effectively spend our resources, right? How do we make sure that we're giving patients the appropriate amount of resources and transports? And so what you see here is red criteria. These are high risk for serious injuries. You can see mental status signs, vital signs here. So if these get checked off, right, they're probably a red criteria, but also injury patterns. So you can see penetrating injuries, head, neck, torso, skull deformities, spinal injuries, chest wall instability, right? You can see the list here. And then you also see yellow. So let's take a look at the notes. When feasible, patients meeting the high risk or red criteria should be transported to the closest level 1 or level 2 trauma center by air or ground. Level 2 trauma centers should not be routinely bypassed for level 1. If not feasible, transport to the nearest level 3 or 4. Right? So the way trauma centers work is 1 is the highest, and then they go down to 4. 1 and 2 are pretty close to interchangeable. So when we say a trauma center, that means a level 1 or a level 2. The only level 1 we have is Dartmouth. Otherwise, you're probably going to level 2. And if you look in here, so for example, Concord Hospital, it shows you level 2 trauma center. Whereas if we go to a much smaller, let's look at Huggins, right? They're not even designated, so they don't have, they don't land on the 1 through 4. Let's take a look at, I'm trying to go. And then Dartmouth, you see, is a level 1, and they're actually also a level 2 pediatric trauma center. So you can get separate trauma center ratings based on adult and pediatric. So what you actually see here is don't bypass the level 2 to go to the level 1, basically. If not feasible, you can transport to the nearest level 3 or 4, or an acute care emergency department. Ideally, you go to the level 2. For a child under 15 years of age, direct transport to a level 1 or 2 pediatric trauma center is desired, right? And so you saw in there, Dartmouth Hitchcock has that pediatric trauma rating. So whatever area you work in, you should be familiar with the different services, what your hospitals have and do not have, so you can best make your transport decision. And then also, if you have red, you're calling a trauma alert for these folks. Yellow criteria, you're seeing EMS judgment. So, anticoagulated, suspicion of child abuse, high resource healthcare needs, burns. But you also have high risk auto crash, partially complete ejection, significant intrusion, so stuff penetrating into the cab. Death in the passenger compartment. So if somebody else dies in the vehicle accident, that basically automatically kicks off a trauma alert. Kids that are unrestrained. So if the ride is separated from the transport vehicle with significant impact, pedestrian bicycle is thrown, run over, or with significant impact, fall from greater than 10 feet, all ages. So you can either do fall from greater than 10 feet. I often go with fall that's twice the height of the patient. Patient meeting any one of the yellow criteria who do not meet red criteria should be transported to the closest trauma center. So that's here 1 through 4. Contact destination hospital, activate the trauma system. So that's calling a trauma alert, right? TBI. So traumatic brain injuries we talked about. So this lands in for our adults and our pediatric patients. So you can do your routine patient care. If their breathing's inadequate, ventilate with 100% oxygen, utilizing normal ventilation. So that's your basically a breath every 6 seconds for adults, breath every three for your kids. You're targeting a pulse oximetry greater than 90%. If you have Capno available, you know I love Capno, right? I love N-Tidal. We're ventilating to maintain uh, N-Tidal of 35 to 40 millimeters of mercury. Do not hyperventilate unless clear signs of cerebral herniation. So that's the brain being pushed out of the base of the skull. So what they used to teach quite a bit is if you had someone who had an increase in intracranial pressure, we'd hyperventilate them. And that hyperventilation, oh, it's been a while since I thought about this, but basically the hyperventilation would blow off CO2. Um, and that CO2 is a vasodilator. And so by blowing it off, you get vasoconstriction. Like you see the steps here. Basically, the teaching used to be, oh, you'd hyperventilate the patient, but they've mostly moved away from that. But if signs of cerebral herniation are present, so that's the brain getting pushed down, and your signs of that are going to be profound altered mental status, maybe positioning, respiratory rate maybe going away. They're going to be circling the drain. Maintain a CAPNO of 30 to 35, and if capnography is not available, you can ventilate adults at 20 breaths a minute, kids at 25, infants at 30. So even then, it's not like a lot of hyperventilation. Discontinue the hyperventilation if when signs, symptoms improve. Assess and document pupil area response and GCS every 5 minutes. You should always be assessing pupil area response and GCS on all of your patients, but here it's just telling you to incorporate it into your routine vital signs, right? And then a high priority patient, we're doing that every 5. So you're checking blood sugar. For moderate to severe traumatic brain injuries, utilize spinal motion restriction, elevate the patient's head no more than 30 degrees. And you see there, we're trying to help kind of flow the fluid out of the skull to help kind of manage this intracranial pressure, right? The pressure that's building up within the skull. We've actually gone over this one, but it's good to take another look, especially as we're in our trauma module. Um, so spinal trauma, this is the same for adults and peds. So patients who have experienced the mechanism of spinal injury, you saw the red box earlier. Um, I think this actually has its own too. But you saw that requires spinal motion restriction and protection of the injury site if they exhibit. So if you have someone who has a mechanism of injury where you might have head, neck, or back injury, they require spinal motion restriction and protection of the injury site if they exhibit midline spinal pain or tenderness with palp. So as I touch, is there pain or tenderness to the midline spine? So right to the back of the patient. Are there abnormal neurologic function or motor strength in any extremity? So if there's weakness, numbness, tingling, right? And you see that numbness, tingling here. If the sensation's not intact or symmetrical, so if you go touch each hand, each leg, and there's abnormality in sensation, so it doesn't feel the same left and the right, or if they don't feel on one of the sides. And then as they flex and extend their neck and or rotate, is there any midline spinal pain? So if they're moving their head up, down, left, right, if any of that causes pain, or even I would say tenderness, numbness, tingling, um, they've bought themselves spinal motion restriction. Or if they cannot competently participate in the assessment due to one of the following. So there's altered mental status, alcohol or drug intox. If they're unable to participate in the assessment, say they're distracted by injuries to self or others, or if there's communication barriers, whether it's language or a disability of some sort. So if they can't participate and there's a mechanism of injury, they get a collar. If they can participate and there's any of these signs or symptoms, um, then they bought themselves a collar. Patients without any of the above findings should generally be transported without the use of a cervical collar or other means to restrict spinal motion. Utilize spinal motion restriction only where, in the professional judgment of the provider, the patient is at a high risk for spinal injury. So longboards we don't do anymore, so you're getting in after that. Elderly patients are a high risk for occult cervical spine fractures despite absence of neck pain. Consider placing a collar on all older patients, 65 or older, who have a high mechanism of injury. So then we see our pearls. Secondary injury to the spine often arises from increased pressure. While the optimal treatment for secondary injury has not been established, providers should protect the injury site. Protecting the site from pressure may be as important as reducing spinal movement. In some cases, extrication of a patient using traditional immobilization techniques may result in greater spinal movement or may dangerously delay extrication. Patients with penetrating trauma do not require spinal motion restriction. All patients who have suffered possible spine trauma should be handled gently, and spinal motion should be minimized. So even with neurologic deficits caused by an injury to the spinal cord, additional movement will not worsen an already catastrophic injury. Emphasis should be on airway and breathing management, treatment of shock, and rapid transport to a 1 or 2 trauma center. Caution should be exercised in older patients and in very young patients, as spinal assessment may be less sensitive in discerning spinal fractures in these populations. So you actually then see here, what do? We do our routine patient care. We're going to maintain manual inline stabilization during the assessment, minimize spinal movement during the assessment and extrication. If a patient requires spinal motion restriction, you can apply a rigid cervical collar. If it doesn't fit properly or the patient poorly tolerates it, you can apply soft collar, towel roll, or padding. And this is my favorite right here. Self-extrication by patient is allowable if patient is capable. So if the patient can get themselves out of their current spot, they're allowed to do it. A long backboard, scoop stretcher, vacuum mattress, or other appropriate full-length extrication device may be used for extrication if needed. Don't use a short board or a KED. And it's only for extrication. If you have them on a scoop and you extricate them, once they're out, you take it off, right? So they're going to be transported directly on the stretcher. We want to apply adequate padding to prevent tissue ischemia, minimize discomfort, maintain spinal neutrality after removing helmet or pads. I try to keep them in an anatomically neutral position. You can allow ambulatory patients to sit on the stretcher, then lie flat. You'd position the backboard of patients on the stretcher, then remove the backboard. Situation or treatment priorities may require a patient to remain on rigid vacuum mattress or backboard, including combative patient, elevated intracranial pressure, rapid transport of unstable. With patient laying flat, secure the patient firmly on all the stretcher straps, leave the collar in place, instruct them to avoid moving their head and neck as much as possible. You can elevate the stretcher back only if it's necessary for patient compliance, respiratory function, or other significant treatment priorities. A patient with nausea vomiting may be placed in a lateral recumbent position on one of the sides, left or right, as long as you're maintaining a neutral head position. So pediatric patients requiring a child seat. If a child requires spinal motion restriction, transport them in a child safety seat device, apply the collar. You can use towels, padding, if it's an infant or they don't tolerate it. Patient may remain in their own safety seat after motor vehicle crash if it meets the 5 criteria listed in 8.12. And if required treatment cannot be performed in a safety seat, secure the patient directly to the stretcher using padding and pediatric size restraints. So you see down here the mechanisms that indicate a high-risk spinal injury: motor vehicle crash greater than 60 miles an hour, rollover, or ejection. Low-speed rear ends can usually be excluded. Falls greater than 3 feet or 5 stairs, or patient standing with feet 3 feet above the floor. Axial load to the head or the neck, so diving accident, heavy object, falling onto head, contact sports. significant injury or mechanism of injury above the clavicle, injuries including motorized recreational vehicles, bicycle and truck collisions. And then you see here that it's got like a kind of an algorithm, which honestly, I just find this more confusing than not.